All right. Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today we have a fabulous returning guest here to talk about her recent paper examining surrogate decision makers and questioning their choices and their capacity. Catherine Drabiak is a professor at the University of South Florida College of Public Health and College of Medicine. She's also a member of Advent Health's Medical Ethics Committee and has numerous publications in the field of law and ethics, which we are deeply appreciative of. Our format for today is going to be a presentation followed by some time for questions from the audience at the end. So with that, Catherine, welcome, and I will hand the mic over to you.
Thank you so much for having me. Again, I'm Catherine Drabiak, professor in the College of Public Health in the University of South Florida, and I'm so happy to be here to talk to you about this question of what happens when there's either a surrogate or proxy decision maker where we might think either they don't have the correct capacity to make the judgment, or we're kind of wavering over how they're making their decision. So that's a bit about what I'll be talking about today. So we'll walk through the legal standard, we'll walk through what it looks like questioning the decision maker, and then that separation between questioning the decision maker's judgment and then does this person lack capacity, which is two different questions, and then the standard for removing a decision maker. And I want to acknowledge my co-author on this, Dr. Gregoire Callan, who was a medical student at the time, and he worked on part of this with me as his capstone research project. And there's a link to the paper here. So this actually arose from a case as part of my work as a medical ethicist at Advent Health Tampa, here in Tampa, Florida. And we had a 92-year-old man come in, and he had multiple comorbidities. This was during COVID-19. He also had COVID-19. He had nutrition and hydration. He had a ventilator. And the physician in this case, the attending stated that we don't think that he's going to make a recovery, and that it would be best to transition to comfort care measures to withdraw nutrition and hydration and the ventilator. His wife, we had determined, was the appropriate decision maker. She agreed with the physician in this case. So then the question that came up was, at the bedside, the adult grandchildren were also there. And they said, grandma has dementia. She should not be making grandpa's decisions. So this really raised a host of questions of, well, how do we know? What do we do when this question of capacity comes up? And then is it a question of capacity or simply a difference in how the decision maker is evaluating the evidence? So you all are familiar with how this works in terms of state laws, which each are a little bit different depending on what state that you're in. So Florida actually defines surrogate and proxy differently than some other states do, which was relevant to this case. So Florida defines surrogate as somebody who the patient specifically designates, versus proxy, which would be the default by state law. Most other states use these interchangeably. So sometimes that's a bit of a difference between states. Every state has a law about, well, what happens if nobody has been designated by the patient, these surrogacy ladders, and these are quite helpful. But that's only the first question. So who's been appointed based on the state law, then what do we do from there? So as you work through a lot of the cases that you're probably called into and working on, either there's substituted judgment standard, so what the patient would have wanted, or the best interest standard, what's in the patient's best interest. And this is another question that comes up a lot of trying to disentangle whether the medical decision maker actually thinks it's in the patient's best interest or it's what the medical decision maker wants. So sometimes that's hard to parse out. So part of the reason of having these default laws, again, for clarity, I'll just call them surrogacy laws, for clarity of terms, is it recognizes the ethical reasons why patients want family members making their decision. So we might think, well, clinicians have all the information, right, that they can kind of direct family members into the correct decision. But family members are looking at a lot more things sometimes than just the clinical criteria or the clinical facts. And so family members might know the patient's history, their preferences, the context of where this condition or decision comes up. And then in many cases, this vacillates over time depending on the patient's condition. And so the family member can help evaluate that and really serve as an advocate for the patient, not just looking at the clinical decisions, but the much broader social, emotional contexts that these decisions happen in. So that's another thing that I think comes up a lot in these cases is it's oftentimes not just one family member. It is a lot of people at the bedside coming in and out, perhaps at different times, perhaps communicating with different members of the care team, and oftentimes with very different versions of what's going on. And so part of this is a communication strategy to make sure that all members of the care team are in some way kind of communicating the same pieces of clinical information about diagnosis, prognosis, and in these end of life cases, kind of the plan for action based on the patient's prognosis, wishes, and values. And focusing on the clinical criteria can really help guard against potential for ageism, overtreatment, undertreatment, or bias, which interestingly, in some of the literature for older adults, it goes both ways. There's some literature on overtreatment, there's some on undertreatment, and then some on age-related bias. And so it's important to kind of connect whatever the decision is, particularly to transition to comfort care based on clinical criteria, not the patient's age alone. So there's also sometimes communication difficulties that might come up with one patient, with one family member thinking that it should go in a particular direction, such as continuing aggressive measures. In this particular case, that's what the grandchildren were saying is, we think that grandpa would want, we think it's best that we continue aggressive life-saving treatment for him. And so some of this connects to reassuring the family members of what has already been done, that we've already exhausted all potential remedies. And then some of this also gets to clarifying potential misconceptions that the family might have for recovery or a chance at regaining potential function. So some of this also is reassuring the family everything has been done, but then at the same time identifying who the legal decision maker is. So in this web of all of these different people around the patient's bedside, going in and out of the room, I think it's also important to distinguish to the rest of the family the purpose of their comfort and care and support and how meaningful they are to the patient, but at the same time disentangle there's one person, in most cases, depending on the situation, making the patient's medical decisions legally. So the next question is, well, how do we know that the decision maker is acting in the patient's best interest? So some of this goes to one side of the question of what is the clinician's duty to make sure that the medical decision maker is acting appropriately. So the first question is the right person selected? And this is something that still comes up sometime, even though we know kind of who in the state surrogacy laws who's supposed to be the person who's serving as the medical decision maker or surrogate might not be the correct person. So that's always, even if we think we know, it's always kind of a check of, is this really the right person? The second thing is making sure that this person can reasonably fulfill the role. So there's all sorts of issues that could come up here that we've seen in our ethics committee, where it appears that the decision maker might be motivated by financial gain if they're receiving some type of government benefits, if the person's uninterested, isn't returning phone calls, isn't communicating with the care team. Potential evidence that the medical decision maker might be physically abusing the patient, particularly in Florida. We have a lot of older adults. This is something that might come up. And then the last question, again, I separate this out because this is a bit different, but potential allegations that the decision maker himself or herself lacks capacity. So again, I'm separating this out because this raises other sorts of questions. So how do we know if it's on one side simply a disagreement with either the care team or a disagreement with other family members versus really, I don't think this person can evaluate correctly the clinical information and manipulate it, that they somehow lack capacity. So it's two separate questions to go through. And I think that's important is it's not a question of if the decision maker is making a choice that looks bizarre, suboptimal, unwise. It's a question of is the decision maker able to manipulate information to evaluate the clinical factors and make a decision where it looks like that person has capacity, which we presume. So some of the literature that is referenced in the paper looks through some of these exceptions where it might be what I would call a red flag to investigate further. So these might be situations where it looks like the medical decision maker is making a decision that conflicts with previous wishes that the patient had documented that are written down. And it looks like there's a mismatch there. That would be a red flag. The second possible exception would be, well, if we start to go down that spectrum of it looks like the treatment is very likely to work, there's minimal risks, there's maximum benefit, so this kind of scale here, but the medical decision maker is declining it, that might also be a red flag, again, for further investigation. The third is if whatever the treatment intervention is would allow the patient to regain capacity, because that's always the choice that we're looking for. Can the patient speak for himself? Or possibly a chance at meaningful recovery. And fourth, what's the severity of the patient's condition? So again, if it's something that seems like a minor thing, but would help the patient, or something, a serious condition that is treatable, but the decision maker is declining it, that's where we would start to say, it looks like a potential issue here of decision making and capacity, not just a difference in values. So how do we know that the surrogate or proxy might have questionable capacity? So the case that we were looking at, there was allegations that grandma, in this case, had dementia. So other things that might come up in different sorts of cases might be things like developmental disorders, mania, intoxication, psychosis, autism, or delirium. So any type of cognitive, psychological, mental disorders, any type of these conditions that might impair consciousness, memory, clarity of thought, people's attention or communication skills. Again, I would pose this as a question mark for further investigation, because some of the more recent literature is positing that, well, perhaps these people may shift in and out of capacity. So how do we still take some of their decision making in terms of evaluating what it is that the patient wanted? But at the same time, making sure that the patient has a decision maker who's fit to serve in this role. So this is an extremely tricky question. So looking for capacity is the same as looking for capacity informally as you would do with another patient. So these 4 factors of, can the surrogate or proxy, the medical decision maker, voice evidence of a choice? Do they actually understand the risks and benefits? Can they manipulate the information? Is there some type of logical thinking? And do they appreciate the consequences of either accepting or declining the particular treatment? One of the interesting things that has come up here is looking at some of these questions of capacity based on the literature appear to be related to misunderstandings or misconception of medical information. So the clinical information and this communication between sometimes the physician or the care team and the family members. That is, there's somehow a disconnect in the way that the physician is communicating the information and disclosing it, and the way that the family is hearing it. And so some of the more recent literature has brought up this idea of using a consultation liaison psychiatrist as simply a communication bridge, and kind of this third party, what I would call a translator, right? To make sure that the physician is explaining the medical information in terms that the family understands, and then checking to see, is the family hearing what it is that the physician thinks that he told the family? So this is not only a question of capacity, but also communication back and forth to make sure that they're speaking the same language. So what are the ethical stakes here? We've walked through the law, we've walked through some of these questions clinically, how to handle the situation. So why does this matter ethically? As I mentioned, patients are entitled to a decision maker that's actually legally fit, that's making a decision in their best interest. And this is because as people, we care about our family members, and this is a reciprocal relationship. So the family member or the loved one, whomever is making the decision as the medical decision maker, we hope, cares about the patient, and the patient cares about their loved one. And so this relational autonomy and this privacy between the patient and the decision maker. So the research also shows that the patient values this person serving as their decision maker because they feel like they're protecting their values, their interests, and they value them in this role. And so there's this idea of a duty. So the medical decision maker has a duty to the patient of intimacy and connection. So this is really the bridge between some of the clinical things of making sure that decisions make sense, and that the outcome makes sense based on the patient's diagnosis, prognosis, and potential for what's happening in the future. But then the family members looking at this in the larger context as well. So what happened in this particular case? It came back to the Medical Ethics Committee, which it may in other cases as well, to figure out, is this a disconnect in the clinical information? Is this a disconnect in, does the medical decision maker actually have capacity? And in this case, it turns out there was no more evidence that grandma had dementia. So we started asking more questions of, is there a diagnosis? Is there other evidence of it? And there wasn't. And so in other cases, how would this get resolved? You want to make sure that it's more than what I call the 3Ds, decision makers that are disengaged, disagreeable, or difficult. These difficult family members, as I've heard from other medical ethics committee members, that slam doors, that yell at the staff, that yell at physicians. So as difficult as these interactions may be, that alone is not a reason to try to remove remove the decision maker, it is a time to call in additional support, either spiritual care or the medical ethics committee. And finally, in Florida, as in many other states, the law actually requires going to court and presenting evidence that would be clear, compelling, and significant to actually remove the decision maker. So wrapping it all up, the law gives us this procedural mechanism, who's the decision maker, but it leaves a lot of questions unanswered of how do we make sure as clinicians that this person is actually serving correctly in this role, that this person is advancing the patient's best interest, and that the medical decision maker has capacity to do this. And so finally, removing that person should be a rare last resort. Thank you so much for your attention.
All right. Thank you, Catherine. We've got some time for some questions. We'll open it up. We've already got two. I'll ask one. I know that Nicole has got another, and then we'll go on from there. So my question for you is about cultural authority. So you talked about legal and ethical approaches to this decision. How do you factor in a patient who values a very different cultural authority, where maybe a community leader or a family member that is very different from the state surrogacy ladder wants to function as a proxy?
That's a great question. And so I think that's it's one of those times where you would have to balance what does the law legally require in terms of who is actually communicating on behalf of the patient, who's signing the paperwork. So making sure that everybody in the situation, the patient, if they can still speak, that all of the other family members know who's legally the decision maker, but then I would say permitting input as appropriate from other people who may have a vested interest in that person and kind of their clinical situation.
Okay, so it's still making sure that you're doing what is legally required of you, but sort of bringing them both together to find a medium. Gotcha. Lovely, thank you. Nicole.
Hello. I was wondering if you had any experience or knowledge in situations where either the healthcare representative who's been designated or a next of kin / healthcare proxy wants to be or believes they have the power to decide who can and cannot visit the patient if the patient is not able to express their wishes.
Oh, a fascinating question. That's actually not one that we've come across, that I've come across. So I think that that would be a difficult one, because the question again comes back to how do you know what it is that the patient actually wanted? And so trying to, I would say, elicit that information from, and this is just off the cuff, elicit that information from as many sources as you potentially can. Perhaps not just that one medical decision maker. So if we think of the medical decision maker in that role of trying to safeguard the patient values, preferences, interests, there are, I would say, in some families, situations where you don't want to see a particular person or a family member. And so trying to elicit, is that person trying to serve as kind of like a guardian and a protector? Or is that person trying to be more controlling in an inappropriate way? So I think it might take more information to figure that out. Great question.
So case by case.
Yeah.
Okay. Thank you.
Hi, thank you so much, I want to say, for this wonderful presentation. This is Dr. Batty, and I have Natalia and Kara over here too. We actually had a case like that caused a lot of moral distress, and I would have been, grateful if you were actually very involved. So I want to thank you about this presentation. And I think your presentation has resolved a lot of our moral distress of removing the surrogate. We had a lot of distress about the decision. Should we just keep continuing on working with the surrogate, or is there a process where we should remove that surrogate? And now I understand is that should be our last resort. I also appreciated your input because we did most of the things that we did involve legal, we did involve ethics, and we did involve spiritual care. And actually our chaplains were key in getting a decision from the surrogate. Our surrogate also had someone that she trusted in the community, and we encouraged her to talk to that person, although she would not invite that person to the meetings. But it's just that that is very common. So I really appreciate your, this insight. Yeah.
Thank you.
That's what I can say. Yeah.
All right, Catherine, I think we just have one more question, then we'll let you go. So this is kind of a question about competing state laws. So here in Milwaukee, we're not very far from the Illinois border. And so some of our patients will live in one state, get care in the other, get care in both. Illinois has a hierarchy ladder. Wisconsin is one of those rare states that does not. And so, for those people that may have feet in two different places, how do you advise we approach conflicting laws on surrogacy and which one takes priority?
Oh, that's a great question. So to not misspeak, I would always say, ask legal.
Sure. Yeah, fair.
But the practical answer is I would separate out the law that's governing what's going on in your institution, meaning that would be governed by your Wisconsin state law versus documents that might come from other states. So if there's an advance directive, a living will, any other document specifying who the patient wants to make their decisions. So I think that's a way to separate out of, if there's nothing, you follow what Wisconsin state law is. If there's a document, you follow what the document is from that particular state.
Okay. And I know Wisconsin has legislation that says that they will honor other states' documents. So that rarely is an issue, but I find it perplexing when they have this hierarchy law and maybe it's a different person who would be making decisions in Illinois as it potentially could be here. But I hear you saying, first and foremost, talk to legal, but perhaps as a generalization, maybe a starting point, you can always lean on where you're getting the care probably falls under what you should follow.
Yes, and I think that's also a good point. Check with legal, because we've had physicians in our hospital that have moved from other states, and there's sometimes strange, tiny little differences of how the surrogacy hierarchy is, of kind of where they're listed, if they're second or third, or, for example, if there's adult children, like how that works in the state law. So even if there's a physician where they knew what it was in the other state, if you move, it's a whole nother ball game. So that's what legal is for. Yes.
All right. Thank you, Catherine. It was such a pleasure having you back.
Thank you for having me. Have a great day.
All right.
Bye.
Bye, guys.